Well, hey there, and good evening to everyone. My name is Dr. Randy Fink, and it is time for Fertility with Fink and Friends. Live tonight from Tulsa, Oklahoma, where I am visiting and working with my dear friends at the Missouri Center for Reproductive Medicine. It's my honor to be here as we are every Tuesday evening at this time, 5 o'clock Central Time, which means 6 on the East Coast, 4 in the mountains, and 3 on the West Coast. Fertility with Fink and Friends is the place you want to be to talk about all those things on your mind about women's health, about fertility, about getting that family, about staying pregnant, the pregnancy aspect. And oh my gosh, isn't that such an important part of our lives these days? It's great to see everybody here tonight. I have to say that Tulsa, Oklahoma was a pretty thunderstormy and threatening today, but it seems like every time I come here, it is always raining. And so many would say that I bring it with me, and I reject that notion. Uh, I think it's just like that here sometimes, but I'm sure the sun shines. It's good to be here. Hello, Timmy. Good evening, my little furry friend. I hope you're still there. A special hello. Hello to Fertility Action this evening, as well as my beautiful mother and father in Mobile, Alabama tonight. That's the Bama gal. We have Nurtured Shanna here with us this evening. Thank you for being here. We've got several folks there on the Facebook, YouTube, or let's see, what do we have? LinkedIn, couple of different Facebook posts, YouTube, and let's see, we've got MCRM, we've got New Life Fertility, we've got First Fertility. Here is New Life Fertility's Instagram. This is my Instagram here at Randy Fink MD, and I hope you will do me the honor of following me so that I can share fascinating topics and things with you. Hey, I hope your Father's Day was wonderful. I hope it was a great opportunity to be able to share some love with dads around the world. My intention was to go and visit my own father on Father's Day in Mobile, Alabama, but as it turned out, the logistics didn't work for that because, so where I live in Pensacola, Florida, when you're driving over to Mobile, you have to go. There's really only one way to get back. That's the way that people go to get to the beach. And when they're trying to get back into town, into Mobile from the beach, it turns a 1 hour drive into a 3 hour drive. So that didn't work out. But I had a wonderful Father's Day myself, and at least I got to send greetings and greetings to my dad and to all the other dads out there. A very special day to show all the dads the love that we have. And I was looking back through my stuff, and back when my kids were little, there was always things that they would do in school, the little ones got to do to kind of celebrate both Mother's Day and Father's Day. They would make all the crafts and everything, and I have a wonderful little mug and a cup and a pencil cup and all kinds of fun things that came from Father's Days of years gone by. And boy, those times do go by fast, don't they? And I look back with such fondness on those days, and I am envious of all those who are able to have those small kids again, because the memories are really very, you really treasure those memories, and it was really just like it was yesterday. I do swear. Um, well, let's see here. Shanna has a question for us, and she says, I had a baseline yesterday for an embryo transfer. I also learned that a baby I've been watching is showing early signs of hand, foot, and mouth disease. Should I postpone the FET cycle? Hand, foot, and mouth is a viral disease that is not uncommon. I think as long and to be honest, you're probably immune from that, Shanna. I would think that you have that viral immunity. I also think that it just kind of depends. Well, you said the baseline was yesterday, which means it's another couple of weeks before you will have that transfer. I don't think that should interfere. I don't think that should cause you any problems. I think it really should be fine. The bigger worry would be, well, what happens if you're exposed? Oh, let's say you do your embryo transfer, and then 2 weeks later, you've got your positive pregnancy test, and you're exposed at that point. I think early on in the pregnancy is probably a riskier time for us to be concerned about viral illnesses because they're out there. They're certainly everywhere in the environment. We can't avoid being exposed to viruses, but the riskier time is certainly, I think, in the first trimester. Now, since we're talking about viruses, I want to mention something that we talked about a little bit about last week when we were talking about some of the LGBTQ options, and that has to do with CMV, or cytomegalovirus, which sounds really, really ugly, doesn't it? You have cytomegalovirus. And I think you actually probably do have to say it that way. I think that's part of I think it's one of the rules, actually. Cytomegalovirus is a typically respiratory illness. It's a flu-like illness that about 85% of us have been exposed to as adults. If you contract CMV, or cytomegalovirus, when you are pregnant, you run the risk of having a substantial impact on the pregnancy. Now, in situations where someone is going to be using donor sperm, we always check their CMV status, because if you are CMV positive, then that means that somewhere along the line, you're part of the 85% of us who've been exposed to that virus, and you are therefore immune from getting it again. However, if you are CMV negative means that you have not been exposed to that virus. And if you are exposed to it during pregnancy, you run the risk of infecting the pregnancy, which, as we said, can be really a bad problem. It can be devastating on a pregnancy, and in fact is the number one cause of congenital deafness. Now, interestingly enough, and so we check because, well, if you're negative, that means that you want to use a sperm donor that is CMV negative, so that there's not a theoretical risk of infecting when the sperm meets the egg, infecting that embryo from the very first moment of conception. So if you're CMV positive, well, it doesn't matter. You can have a positive or a negative donor. If you're CMV negative, then you want to get a CMV negative donor. But interestingly enough, and patients have said this to me before, well, we don't test our sexual partners, do we? No, we certainly don't. So what would happen in the environment if a spouse is CMV negative, but the partner is CMV positive, and they're having sex and they get pregnant? What do you worry about in that scenario? Well, that's why I say, again, it is a theoretical risk, but potentially a risk that we can avoid. And that's kind of one of the more important types of viruses that we talk about in pregnancy. Now, the other type of virus that does show itself sometimes in pregnancy is the herpes virus. Herpes virus, particularly the type 2 herpes virus, is a sexually transmitted viral infection that 1 out of every 4 Americans has. And let me say that again, because that is a shocker to a lot of people. 1 in 4, 25.5% of the American population, if we tested your blood, we would find that you are positive for the type 2 herpes virus, meaning to say you have been exposed to genital herpes. Well, and that's a shocker when it comes up, isn't it? Because most of the time people have no idea that they've ever been around it before. So it is something that can be tested in the blood. It's not something we routinely recommend that you test when you're doing, let's say, a panel of tests for sexually transmitted infections, because again, 1 out of every 4 people, and you can count them as you go down the row, 1, 2, 3, 4, 1 out of 4 is going to be positive for the type 2 herpes virus. The significance of that in pregnancy is that if you are positive for the type 2 herpes virus. Then, usually around 36 weeks of pregnancy, so a month before your due date, we usually would put you on a suppressive medication to decrease the probability that there might be any herpes virus around in the time that you're going to be delivering. So, if the plan is to have a vaginal delivery, you want to make sure there's no herpes virus there because it can cause an infection in the baby passing through the birth canal. So that's one of those things that's also kind of a big shocker to people, the herpes virus. Type 1 herpes. Type 1 herpes is the type that favors the mouth. It favors the mouth, the face, cold sores, fever, blisters, that kind of thing. And really, most of us as adults have been exposed to type 1 herpes. So the presence of type 1 herpes around here, it's not worth testing for because almost everybody is positive. The bigger significance has to do with type 2 herpes genitally, although there has been an increase in the incidence of type 1 herpes appearing on the genitals. So, if a patient came in to see me as a gynecologist with a lesion, we would like to culture it so we can look at it and say, gosh, this looks a lot like herpes, but it may just be a type 1 herpes lesion, which means that it was generally transmitted from someone's mouth. And resulted in a lesion that oftentimes does not recur or may recur once or twice, but is not something that has the ongoing recurrent nature that type 2 herpes has and doesn't have the same risk of transmission to a sexual partner that type 2 herpes has, because again, most of us have already been exposed to type 1 herpes. So herpes is another kind of big one out there. And I want to say a special hello to, it looks like Mary Lynn. Mary Lynn says IVF should be cheaper, and I do agree with that. Now, I will tell you too, that there are places that you can go for IVF that will cost you $30,000 for a cycle of IVF. And there is just no need for that. It does not need to cost that much. So IVF can be affordable. And I will tell you also that there are more affordable ways to find IVF instead of going someplace and paying $30,000 for that cycle. Such as, well, look around and say, well, you know what, if the clinic tells you that it's going to cost $30,000 for the cycle, plus the medications, plus, all this and that and the other stuff, frankly, in my opinion, that's just too much. You're paying for a name, you're paying for someone's reputation, you're paying for something that really doesn't need to be like that. And the medications are very expensive as well. So that's a kind of a big add-on, really on top of that. But there are pretty straightforward ways that we can finance IVF in this day and age. The finance options, they're basically medical loans. So they do not have the same kind of interest rates as like putting it on a credit card or even like care credit, which can be very expensive. And also something that I have been finding a lot more recently is there are a number of foundations out there that have money that they have to offer to families who need to undergo IVF. And some of these may be through the church, through your, religious affiliation, through a community organization that you may belong to. Certainly, if you're a veteran or a military family, there are foundations out there, generally nonprofits, that have money to give away to folks who need it for IVF. And so I always say that I really think that it's worth looking into that, because you may just find, and maybe, it's not going to cover the entire thing, but hey, every little penny counts. And if they're giving away money to help you, then it behooves us all to look into that, to be the first in line, to try to be a recipient of it. So, if you're thinking IVF is in your future and the financial aspect of that frightens you, please do Google IVF grants or IVF foundations. Folks who are IVF nonprofit, folks who are giving away money to people in need of IVF, really have found that to be something very meaningful and useful over the last few weeks. I found several folks who have been through that and found money. So we have a bunch more people who have joined in tonight. And let me just say hello, Tara Elizabeth. Hello, Midgie56. Good to see you there. Elena, nice to see you. AZ Signatures, how are you tonight? Indepino Journey, it's good to see you as always. Hello, Lelix3 and Amanda Morrison. Nice to see you there. Avis Barnett, Nina Buena, how are you? And Haley, good to see you there. Shannon notes that, and it's something that I really do want to call attention to. You said, Shanna said something very, very nice to me. Shanna's, I've known you through here for several years now, and you've always been a really wonderful soul and a very nice person. You said, thank you always, as always, for your guidance and support. But this journey can be so isolating, and these talks are helpful. And I appreciate you saying that. That feeling of isolation is really one that I think is very interesting. It absolutely can be isolating, but it's funny because what is isolation? Isolation is that feeling of being alone, that feeling of being isolated, that feeling of being just kind of by yourself. And I think that is a fundamental fear that is hardwired into us because we are social creatures. We are accustomed to being a part of a community and feeling ostracized or thrown out of a community, feeling isolated or alone from a community is really a fundamental fear that we face, really kind of going back to the very foundations of our evolution. But it's interesting that folks would feel isolated during the fertility journey because there are so many other people who are dealing with those same ups and downs and that same roller coaster of emotions, that it's interesting to see that isolation is a part of it, but it is a big part of it. And that's actually something that we're going to talk about in just a few minutes at the bottom of the hour when we do the 5:30 Fuzzies with Fink. So I don't want to preempt my own message there, but let's talk a little bit more about isolation in just a few. Hi, Haley. I think I may have said that before. Hey, Aaron, well, it's not Shabbat Shalom, but Shalom to you in Dothan, Alabama this evening. Hey, Angela, good to see you, my friend. Here's a question from Indepino Journey. Does embryo grading matter if it's euploid, and also what day it is? Well, that's a good question. And it is a common question that has a sort of nuanced kind of answer. So let's take a look at that. The first thing you want to know is that if it's a euploid embryo, euploid meaning chromosomally normal, euploid is euploid, and euploid is the best kind of embryo you can get. That is the embryo you want, right? That's the one that's chromosomally normal, that came from a chromosomally normal egg fertilized by a sperm that resulted in an embryo that grew and created a chromosomally normal embryo. That embryo has our highest probability of pregnancy in the whole IVF world, and that can be up to 65% probability of pregnancy. Now, what about the day? A day 5 versus a day 6 versus a day 7? And the answer there is that, well, a day 5 is really the best type of embryo we could want, because that is traditionally when an embryo becomes a blastocyst. And what is a blastocyst? A blastocyst has gone from a bunch of cells that are just trying to figure out how to divide and how to survive, have transitioned actually into a little functioning metabolic factory. They've gone from being, let's say, 6 to 8 cells when they're a day 3 embryo, and they have become 150 to 250 cells by the time they're a blastocyst. And that change, that transition typically happens day 5. So it goes from what's called a cleavage stage embryo, because it's cleaving, it's trying to divide. It becomes a morula. A morula is like a day 4 embryo. And then that day 5 embryo is a blastocyst. Now, some embryos take 6 days to become a day 5 embryo, and some embryos take 7 days to become a day 5 embryo. And if that's the case, then they have moved along a little bit more slowly than you might expect from than kind of really what happened with the day 5 embryo. So the day 6 embryo is not going to function as well as the day 5 embryo, and the day 7 will function even less well than the day 5 and the day 6. So if you're asking the embryologist to say which is the better embryo, it's always going to be the embryo that became a blast on day 5 as opposed to day 6 or day 7. Now, the grading was a system whereby they are able to look at an embryo. They look at the embryo, they look at the inside parts of the embryo, which is called the inner cell mass. And then they look at the outer parts of the embryo, which is called the trophectoderm. And they're making some assessments on what these things look like. That's what the 2 letters are in an embryo grade. The number has to do with the extent to which that embryo is hatching, like a grade 4 embryo. A 4AA is a very good quality inner cell mass and a very good quality trophectoderm, the part that becomes the placenta. Which part is more important? I don't know. Some people will say, well, gosh, the trophectoderm is the part that's most important because that's the part that has to interface with the mom's uterine lining. It has to implant there. But the truth is, you also need a good inner cell mass because that's the part that becomes the baby. So which is more important? I don't know. They're both important, really. But grading was a thing that we looked at grading to say, well, if we don't do PGT testing, right? If we don't do chromosomal testing on the embryo, can we grade embryos? And will that somehow show us the embryos that are more likely to be chromosomally normal? A higher graded embryo, is that going to be a better embryo? And as it turns out, not so much, because you can have a big group of embryos that you have done PGT testing on, and you may find that your highest graded embryo has complex chromosomal abnormalities, whereas your lowest graded embryo turns out to be euploid or chromosomally normal. And guess what? Your poorest grade embryo is still going to be the highest probability of pregnancy in that scenario because it was the one that was euploid. Euploid or chromosomally normal is always going to be the most important feature. Day 5 or day 6 is probably the second most important feature, and the grade of the embryo is probably the third most cogent feature, because if you plug all these numbers in, basically it can give you a probability of pregnancy. And if you're looking to say best quality embryo, the higher graded embryos have a slightly higher chance of implantation. The day 5 embryo does, the euploid embryo certainly does. And so those are the kind of choices we make when looking to see which is going to be the embryo we transfer. But to answer your question, does grading really matter? It's kind of a beauty contest. And, if you've ever really watched a beauty contest, This one plays the piano better than, this one's talent competition, this one's evening wear, this one's, swimsuit. Does it really matter? Does that mean that any one of them is better than the other one? No, but grading becomes this thing, and I always say this because we've all been through high school, right? We all know that you get a good grade in a class. Well, that makes your parents proud. That makes everybody happy. Everybody, rewards you with this and that. You get a bad grade, and nobody's happy with you, and you don't feel good about yourself. And then you get some position in the class that's based on your grading, the valedictorian. Well, that was the person with the highest grades. So best grade, that must mean that you get to give a speech at your graduation, right? So best graded, that's got to be a good thing. Embryo grading really isn't the same situation. It's really only a way to kind of judge how pretty an embryo is, and the differences those things make in terms of implantation are really on the order of very, very small percentages. So in Pinot, I think I tell people, hey, if you get a euploid embryo, euploid is great. Otherwise, don't worry so much about grading. And everyone is always very concerned about their embryo grades. But I say, it's not like your child is your embryo is going to become valedictorian. It doesn't have that same kind of significance. So very good question there. Let's say over on our New Life Fertility Instagram side, we say hi to Sheila, hi to Sarah. Hi, Liz. Molly K. Casper is here. Shada is here tonight. Nice to see you. As is as is Ruby. And hey there, handsome. She says that's my daughter. She can say that sort of thing. Howdy, baby. Nice to see you this evening, folks. Is it raining here? Well, I am live tonight from Tulsa, Oklahoma, where I am working with my friends and colleagues at the Missouri Center for Reproductive Medicine, and it rained pretty hard. Some pretty big thunderstorms around here today. It gets kind of scary here in the middle of the country, what with the tornadoes and all that sort of thing. If you're over there on the Instagram side, please, or I'm sorry, on the Facebook side, please say hello, because I can't see anybody's name over there. Just on, say hello so that we know you're there. I see that you're there, but I don't know who you are. So, hey, bottom of the hour. And now, as promised, I do want to talk a little bit more about that isolation thing, because here we are. It's time for the 5:30 Fuzzies with Fink. And that is the time during my broadcast when I like everyone to know that they are not alone. So precisely because this fertility journey can feel so very isolating, so much so that you can really honestly feel like you're the only person who is going through this, and that no one else could possibly understand the kind of heartache that you experience dealing with this. And I'm here to tell you that there is a huge community of very like-minded people out there who would give you the shirts off of their backs for you to know that you are not alone. It's not just the fertility roller coaster, which, as I'm fond of saying, is the crappiest roller coaster in the park, but rather it's also the curveballs that life throws us in general. Maybe it has to do with work. Maybe it has to do with family, loved ones. Maybe it has to do with relationships, or your kids' relationships. Maybe it has to do with school. Maybe it has to do with your neighbors, your friends, any of those strife related events that can happen that cause us to feel anxious. They cause us to feel sad. They cause us to feel alone. This is the time when we can all stand together as one community and break the internet with kindness by sending the positive vibes to everyone out there tonight who needs to know that you are not alone. We are all in this together, friends. And I would say it really makes such a difference in the world when you can just try to make a difference in one person's life. Try that tomorrow. Smile at a stranger. um, do something nice for someone. Pay it forward. Pay, somebody's the person behind you's meal at McDonald's or at Starbucks. Or it doesn't have to be about money. It's just about kindness. It's just about giving a little something to someone else, even without being recognized for doing it. Not only does that make you feel good, it honestly and truly makes the world a better place. These random acts of kindness, there's not enough kindness in the world. So please try to share some and send out the positive vibes tonight. Again, for everyone who needs it, you're not alone. We are all in this together, no matter where your pain is coming from. Tomorrow is a new day, my friends, and it is full of all new adventures. So every step forward with hope. And that is the 5:30 Fuzzies with Fink. Thank you for being here for that. By the way, if you would tell your friends to show up at 28 minutes past the hour if they don't want to watch the whole thing, the more people that we can have here at that 5:30 mark, bottom of the hour, to be able to just send out those positive vibes. And I know that sounds corny. I know it sounds silly, sending positive vibes, kumbaya. Yeah. But it really, I think, does change the world. And even tomorrow, if you can do one nice thing for a stranger, then you have truly done something to make this world a better place. So that's my 2 cents worth on that. Hey, Jessica, thank you for speaking up from Facebook. I appreciate that. Hi, Lauren. Good evening to you. And let's see, we've got Elir, we've got Ali is here. Elena is here. Lehume is here. Angela asks if having hysteroscopies 2 to 3 times a year harmful? Could it cause scar tissue? And I would say, well, and I believe in your situation there, my friend, that you're a polyp former, I think. And I think they keep going back and looking in you for polyps, and they looked and you were clear, and then they looked again and you had a polyp shortly thereafter. Some people do make a lot of polyps. And if you make a lot of polyps, then yeah, I think certainly if you're doing fertility treatment, then you want to know that endometrial cavity is clear, that you don't have a polyp there. It takes up valuable real estate that a pregnancy wants to use in order to implant. So the hysteroscopy itself is really very straightforward. It can be done in the office. You don't have to go under anesthesia for that. It's a little tiny camera that can go in, just take a peek, and then you're done. Literally, it takes about 5 seconds in the office, very tiny little camera. You feel one little cramp. I tell people usually it's less crampy than menstrual cramps for most people. Where you run the risk there, Angela, for scar tissue is when you're doing something like scraping on the inside. So a D&C or having an operative procedure inside the uterine cavity runs the risk of creating scar tissue. And that is basically a little band of adhesion between the top layer of typically between the top layer of the uterus and the bottom. And that can obstruct a portion of the uterus and create a hardship in the place that a pregnancy is trying to implant. So simply looking to make sure the cavity is clear, I would not think is something that is high risk for creating scar tissue. Doing a D&C, and some doctors do this every time they take a look, they put in an instrument and they scrape that lining. Now, that's not something that you would really like to have done without anesthesia, that D&C part. But D and C, dusting and cleaning, we call it. It's a dilation and curettage. Dilation means you have to open up the cervix a little bit in order to be able to get inside. And a curettage means it's a scraping. So if we were going to curette the skin, we would kind of do like this. If you go to a dermatologist, they have what's called a dermal curette. And if you have a little lesion, they can kind of scrape it with this dermal curette. Same thing in the uterine lining. But when you do that in the uterine lining, that's when you run the risk of creating scar tissue. So hopefully that is helpful there. Hello, Foxy. Good evening from Minnesota. Thank you for being here tonight, as you are every week, and it is truly, truly appreciated. Hi, Noodles. Noodles, good to see you here this evening. Dragon Meyer and OMG Kylie. Noodles asks, failed euploid transfer again. Oh, gosh, the doctor suggests to go the reproductive immunology route. How can reproductive immunology help if I was already on an immune protocol for medicated FET? Well, gosh, so you, without naming names, you are likely being seen at a practice that offers an immune protocol for every patient. And that kind of goes against the recommendations of the American Society for Reproductive Medicine. But to be honest with you, what we know about these immune protocols is that many of these medications, they are going to help some people. The problem is we just don't necessarily know exactly who they are going to help. And as long as they aren't going to hurt you, then you might be in that group. It's going to help. But there are a number of different immune medications and different types of protocols. So just because you are on one of them, so for example, just because you're on immune protocol 3, that doesn't mean that there aren't other things that may want to be or need to be included. So now seeing a reproductive immunologist is not really an easy thing to do because there aren't so many of them in the United States. They're expensive. Much of the time insurance doesn't cover them. They're hard to get into. It may take months to be able to get in to see such a specialist. So I will tell you that there is a testing profile that you can buy, and that is called Pregmune, Pregmune, Pregmune. And so what Pregmune does is that you sign up with the program, and I've seen different costs on it, so I wouldn't want to quote it, but you can see it on their website, pregmune.com. And what it does is that it orders a whole series of immune blood tests, the same kinds of things that a reproductive immunologist would order. Those things, if they're paid for by your insurance, they're run through your insurance. You typically get them from Quest or LabCorp. And all those results go back to the Pregmune folks, and they're run through their predictive AI software, and it creates this like 68 or 70 page report of your entire immune profile and interprets all that, because that's where it can kind of get a little it gets hard to understand. So there are some basic things that your clinic, your IVF doctor can really help you to understand. But there are some minutia aspects. There are some things that we don't routinely test that are really hard for most of us in clinical practice to understand. And so you do that. It explains it all. It lists it all out. It shows your whole immune phenotype, as we would call it, and really sometimes can open the door to give us some very helpful information about what kinds of things may be going on with you. So I think it might be worth looking at Pregmune, because sometimes it really can help. I'm so sorry to hear that you had to go through with that, and gosh, another unsuccessful transfer. This issue of recurrent implantation failure is one of the more frustrating things that we deal with in our specialty, because there's just not always a clear-cut answer. But what it tells us is that it's time to start looking under those stones and trying to figure out what else could be going on here. So, hello, Zenaida in South Florida. I heard about all the fires down there, and it's because you are smoking, right? Yes, that is right. South Florida's on fire. Zenaida, it's a privilege to be here for you, and thank you for being here as you are on every Tuesday. It looks like Priyate, hello, good evening. And Marlena, nice to see you. How about, Angela says, no scar tissue and septums. Oh, you had scar tissue and septums, maybe. How about natural killer cells? So natural killer cells, or NK cells, are one of those things that Pregmune tests for. But the interpretation of that result is resplendent with controversy. And that is because you can do the test and find that you have normal levels of natural killer cells. And the problem is not the level of the cells. It's not that you're short on those cells or have too many of those cells. It's a normal amount of cells. It's the activity of those cells. It's what they're doing that may be the problem. So interpreting that result can be challenging. Typically, the treatment for problems associated with the NK cells is intralipid, and I believe at the practice that you're going to, they routinely use intralipid. Intralipid is an infusion. Basically, it's a fat infusion, something that is commonly used for folks who are unable to eat and are doing what's called total parenteral nutrition. It provides them the necessary fats in their diet, but it basically functions as a very potent anti-inflammatory, almost like an IV version of the keto diet, and it does suppress the function of the NK cells. So that's usually why we use the intralipid portion of that. Shada liked my dusting and cleaning. Oh, yes, indeed. Does a mosaic embryo have a chance to get fixed by the body? So mosaic embryos are not throwaway embryos. And you'd say, now, what is a mosaic embryo? If you've never tested your embryos before, then you're going to be like, I don't know what you're talking about there. So a mosaic embryo, so when we have a chromosomally normal embryo or a euploid embryo, that means the embryo has two sets of 23 chromosomes, right? So it's a 46 chromosomes and an X and either another X or a Y, and that's the sex chromosomes. A mosaic embryo is where there is an abnormality in a portion of one set of those embryos, or I'm sorry, one set of those chromosomes. You got two sets of 23. So in, let's say, half of this one set of 23, there is an abnormality. That's called a mosaic. There's a high level mosaic and there is a low level mosaic. These two different types of things just depends on how much actually is there that's abnormal. Yes, the body can often fix those mosaics, especially the low level mosaics. Now, the mosaic embryos, when put back, the body has the ability. We have our own DNA repair mechanisms, and so that little contraption at the cellular level can come along and just kind of fix those things, and that mosaic embryo can turn out to be completely a normal baby. So we get a little nervous when we're talking about things in chromosome 13, chromosome 18, and chromosome 21, because those three chromosomal issues can result in a pregnancy that becomes ongoing, a pregnancy that implants and continues, even though it can potentially result in the birth of an abnormal baby. And when I say abnormal, I mean chromosomally abnormal. In most cases, when we have abnormal embryos, they simply just don't implant, right? You just don't get a positive pregnancy test. 13, 18, 21, trisomy 21 is Down syndrome. Trisomy 13, trisomy 18, these are defects that can result in a live birth for a baby that will not continue to survive on the outside, So that's somewhat of an important um, thing to know. So when they're 13, 18, 21, we tend to not want to transfer them. But other types of mosaic embryos are transferable embryos. And I can't tell you the number of babies that I have held in my arms who were mosaics, who they said, oh, no, you should, other practices that said you should throw those embryos away, you should discard them. Or what about the poorly graded embryos? And my friend Elise, the embryologist, says if it's good enough to freeze, it's good enough to give you a baby. The grade doesn't matter. So to answer your question, Shada, yes, the body can fix a mosaic embryo. Let's see what else we got going on here. Elena asks, says, good to see you. It's good to see you as well. What additional tests do you recommend besides PGTA and carrier screening? I am 41 and my husband is 50. So you mentioned, kind of two important things. I do feel that carrier screening is very important because the time to find out, So the thing about it, basically, what that is that it looks to see if you are a carrier of any one of, in this case, 275, as you mentioned, diseases that are part of that panel. Our genome, our chromosomes are very colorful, and it is not unusual to find that we are carriers of a bunch of things. They've actually been able to identify, I think, about 1,200 different diseases and their locations on our chromosomes. You don't need to test for all of them. You really don't. You want to test for the ones that are the most severe, the ones that are going to potentially cause some sort of alteration in your offspring if you were to pass those along. So, one of those things that is kind of not so meaningful might be, single eye partial color blindness. Well, would you really select an embryo based on single eye partial color blindness? Probably not. Would you select an embryo based on a life-threatening disease like cystic fibrosis? Yes, you certainly would. Or sickle cell disease. Of course, yes, you would. So it's not unusual to find that we are carriers of different things. And really, the only thing, I may test partner one who carries 10 different things, and I may test then partner two who carries 20 different things, but it doesn't matter as long as they are not both carrying the same thing. And that's really the only thing that matters. As long as they're both not carriers of the same thing, then the carrier screen was a box to check off. It's good to know that you're not both carrying the same thing, because if you are, it's a 1 in 4 chance of having an affected baby. Again, time to find out about that is before you get pregnant. PGT testing is somewhat controversial, actually, believe it or not, over the age of 40. And let me tell you why. The big issue that you have over 40 is that we know that the majority of the eggs in a woman over 40 are not actually going to be normal eggs. So when we retrieve these eggs and we fertilize these eggs, if the egg wasn't normal, first thing that happens is nothing happens, right? Nothing may happen to that embryo. They may look at it the next day and it just didn't fertilize. Or it may fertilize and start to grow, but then it stops growing. So that's one reason that we might grow out to the blastocyst stage, because growing out to blast means that you're letting nature help you to select that first group of embryos that has the higher probability of being able to get you a baby, right? So it's a selection methodology. Some practices will transfer day 3 embryos, Problem is with a day 3 embryo, we just don't know what you're getting. We don't know if it was normal. Would it continue to grow? Um, just don't know. So it's very, very hard to say under that scenario. But um, um, over 40, the majority of your embryos a majority of your eggs are going to be abnormal, strictly based on the date that's on your driver's license. You know, so there's really two strategies. One is, okay, if you get a whole bunch of embryos, let's say that you make this many eggs. If we get this many eggs, this many of them are going to fertilize and make embryos. And then we start to grow those embryos out. This many of them make it to day 3, and this many of them make it to day 5. So we're narrowing that cohort as we go along. If we still have a bunch of embryos there at day 5, the PGT testing becomes very useful because we can use now some science to help us take this group of embryos and narrow it down to this group of embryos, because those are the ones that are going to have the highest probability of getting us pregnant. That's really the best purpose of PGT. In many cases, folks who are over 40 may not make that many embryos. And so let's say that you make 2 embryos, or you only make 2 blasts. And I would say there's no real benefit to testing those 2 blasts, because we can just transfer both of them at the same time. The likelihood that they are both normal is very low. So the risk of twins is very low. But if they're normal, if one's normal, it's going to stick. If it's not normal, it's not going to stick. So your body is going to give you that same information that you would have otherwise paid a lot of money to get from the laboratory. Now, the group in whom PGT really does make the most difference is women between 35 and 40. And I apologize. Well, you say you're 41. So, it's not that it's an unreasonable thing to do. But again, the goal is to take a larger group of embryos and to narrow it down to the ones that are more likely to be normal. But between 35 and 40, that's the group that is still likely to get a bunch of embryos and start having issues with those embryos being normal. At 35, about 5 out of 10 of your eggs are going to be normal. So at that point, it becomes very useful to know which embryos are normal. Not only is it going to save you from potentially unsuccessful embryo transfers, but it's going to give you some peace of mind that what's going in you is likely going to, or certainly more likely going to work. So between 35 and 40, it increases the probability of a live birth. And that's my point there. If you're under 35, it may be convenient for you to know. You may want to know because you get to learn the gender. If you've had recurrent pregnancy losses, then yep, I think you do want to know that those embryos are chromosomally normal, because that takes off the table the most common reason that folks miscarry, and that is those chromosomal problems. And certainly between 35 and 40, it saves you. If you're over 40, yeah, it's nice to know that it's a normal embryo, because again, you're going to face the mathematics that more of your embryos are likely to be abnormal than not. But if there's only a few embryos, I would say a different strategy is just transfer the embryos, and they either stick because they're normal, or they're not, or they don't stick because they're not. Now, the other thing some people do over 40 is to say, well, I'm going to do multiple cycles, and I'm going to bank up my embryos so that I end up having a lot more embryos to test. I'm not just, maybe I do one cycle and I get 2 embryos. Well, and then I'm going to do another, and it wouldn't be, according to what I'm saying, it wouldn't be worth doing that PGT testing for 2 embryos. Well, but then maybe you do a second cycle and you get 3 embryos. And then you do a third cycle, and maybe you get another 3 embryos, and maybe you even do a 4th cycle and you get 4 embryos. Well, at that point, you've got 3, 6, 7, 8, and 4, 12 embryos. And then heck yeah, it makes all the sense in the world to do PGT testing under that circumstance, because you've got a broader group of embryos that the PGT is going to help narrow down to the ones that are shown to be chromosomally normal. Now, PGT testing isn't perfect, but it's the best we have right now, you know. Hello, Ackland, and let's see. Oh, but Elena, to answer your other questions, are there any other tests that you need to do? And I would say no, but I always like for folks to be on. There is a supplement protocol for older moms and folks with diminished ovarian reserve that can make a difference in terms of egg quality. So I think that's an important thing. But also depending on how mature we get, you know, for moms that are going to be over 45, I usually like to know that you've seen an OB doctor who agrees to take care of you, because some of them are very risk averse and will say, oh, nope, that's too high a risk pregnancy for me. So yeah, we don't take care of people that are high risk because our insurance company won't allow it. So I think it's useful to to kind of line those things up, and just to make sure that things like your heart and your blood pressure and things of that nature, your blood sugar and so forth, are all at their healthiest, so that you have the best possibilities of having a healthy pregnancy and delivery, and to go on to enjoy those many years together with your kids. Well, folks, we are going to, and Shada, thank you for being here. I appreciate your words. And thank you, Jessica, also for saying such nice things to me. Thank you very, very much. Folks, this, like I said before, this fertility business, it's not the book of your life. It's really just a chapter. And what are we doing? We are going to rewrite that chapter here together. Every step forward with love, every step forward with kindness. Remember what I said, change the world tomorrow. And you can do that one interaction at a time. Every step forward with hope, because tomorrow is a new day and it is full of all new adventures. My name is Dr. Randy Fink, and I'm a fertility gynecologist at New Life Fertility in Pensacola, Florida, with offices in Mobile, Alabama, and Panama City, and also at the Missouri Center for Reproductive Medicine in St. Louis and Tulsa. And live from Tulsa tonight, thank you so much for being here. I appreciate it and wish you all the best. Good night.